Thank you, Dr. Chopra and Dr. Mani, and I must thank Dr. Agarwal for organizing this beautiful event, as you already mentioned. And this topic of antiplatelet therapy is actually very important these days because we have talked about intervention in the previous talk, but how to maintain this intervention? That was the problem, because when we did all these interventions, thousands and thousands of stents were implanted, but we also started seeing that many of these stents started failing. They started getting occluded. So to maintain these patients with the patent stent, we wanted to have a good therapy, good treatment. And this is what we call as prevention of this intervention. So this dual antiplatelet therapy is what I'm going to introduce to you, because you all must be seeing these new medicines like clopidogrel, prasugrel, which has been added to the treatment of coronary artery disease. So what is the role of this and how we are using this for secondary prevention and long-term prevention of these events in those patients who have already received the stent. And this has been found that the incidence is very high if we don't use antiplatelet therapy, and that is what I'm going to discuss with you in another 10 minutes. So what is the evidence supporting dual antiplatelet therapy? Why do we need two antiplatelet agents in a given patient, and for how long? 12 months or more? So one of the studies which was done earlier showed that when we add a tablet, as mentioned by Dr. Chopra, ticlopidine, which was one of the first entrants as a second antiplatelet agent, showed that there is a benefit in reducing complications. And thereafter, since ticlopidine was having a complication of neutropenia, in addition to decreasing antiplatelet effect, it also had neutropenia. So a new drug came up into the picture, which is known as clopidogrel. So to make it very simple, clopidogrel was well tried in patients having acute coronary syndrome and patients who have undergone angioplasty and patients who have acute myocardial infarction. So clopidogrel was tried and it showed that it has benefits in addition to aspirin. So if you add clopidogrel in addition to aspirin, this is what is shown in this graph, that the endpoints of death in heart attack or MI and stroke it decreased, which is very, very important. So at 12 months, which is 1 year time, if you add clopidogrel to aspirin, it will decrease complications. So that is why clopidogrel became the standard of care in addition to aspirin when patients received stents. That is very important. So all these patients who have drug-eluting stents these days must have clopidogrel. Otherwise, your treatment is incomplete. I can do a very good angioplasty, but if my patient doesn't take clopidogrel and aspirin for next 6 months, 8 months, 1 year, then the total treatment is a waste. It is a waste for everybody. And that is why it is very important. That is why I think Dr. Agarwal took this topic, that many times interventions are done, but the follow-up is not adequate. And that is why we have seen that these patients need treatment. But then the second thing, many physicians fear that if you give two antiplatelet agents, there will be more bleeding. Bleeding complications, bleeding from the stomach, bleeding from the piles, bleeding from the brain, anywhere it can bleed. But it was tested again that when it compared to placebo, clopidogrel did not lead to any significant bleeding complications at 30 days and at follow-up also. So it is safe to give clopidogrel for long-term treatment, maybe for a year or more than that, in patients who receive stents. So it is very clear. Then the second treatment group which was discussed was ST elevation MI or acute myocardial infarction. Whether in acute MI, in addition to thrombolytic therapy, clopidogrel and aspirin should be given or not. It was well tested and it showed that if you give clopidogrel, it is better in addition to aspirin and thrombolytic therapy to decrease the endpoints of death and myocardial infarction. So clopidogrel is recommended for all patients who are having acute myocardial infarction from day 1 and will carry on till 1 year at least. So this is the recommendation. And again, bleeding complications were tested. It was not high, and that is why it is safe to give medicine, both aspirin and clopidogrel, which is known as dual antiplatelet therapy, to all patients suffering from acute myocardial infarction. Whether they undergo angioplasty, whether they undergo a bypass surgery, still they must receive dual antiplatelet therapy. And this has effect on both death, reinfarction and stroke. So this is very, very important. So this is very good, but there are still limitations of aspirin and clopidogrel. Not all patients will respond so well. Not all patients will live so well. Why? Because there is variability in each patient's response to this therapy. Because clopidogrel is actually having some resistance in some patients. They don't respond so well, and that is why many patients will still have complications like stent occlusion, like recurrent myocardial infarction. For example, if a patient has a stent, 6 months later he will again have acute myocardial infarction from the same artery. Why? Because this patient is resistant to clopidogrel. So how do we find out that which patient is resistant? And let me tell you, this is the first test, at least for myself, I don't know of others. For the first time, I am using a genetic analysis for my patients on a routine basis. Earlier, we were just hearing about it. Everybody discussed about this, the genetic analysis can be done. But this is the first time, this is a very simple test. We do a buccal smear of the patient and put that strip, like the glucose strip, we put it into the machine, and in 1 hour time, it gives us a result whether this patient is having a gene mutation, which is known as the CYP2C19 allele testing, which is so simple now. You can imagine that how far we have gone, and this will tell us whether this patient is going to be clopidogrel resistant or not. And this is a very simple, very cheap test, which we do now these days, and this can prevent complications. And this has been shown in these trials, as you can see here. Those patients who are non-carriers will have less complications compared to those patients who are having a carrier of this gene mutation. And that is why they are resistant to clopidogrel. And so all patients who are high-risk patients, where we have put 3 stents, 4 stents, like Dr. Pramod said, there we are wanting to ensure that the stent should work well. How do we ensure that? We do this test before they leave the hospital, takes about 1 hour only, and just a buccal smear only can tell us whether this patient should be put on clopidogrel or not. Then the question is, if they are clopidogrel resistant, what should we do? The next generation of antiplatelet agent which has come up is known as prasugrel. As you will see here, this yellow, prasugrel is a new antiplatelet agent which can be used in these clopidogrel resistant patients. And it has shown good results in many studies, and one of the studies which has been done is known as the TRIMI 38 study, which showed that if you use prasugrel compared to clopidogrel, it is better. So prasugrel is a more stronger antiplatelet agent, more efficient antiplatelet agent than clopidogrel. But we can't use a very, very strong drug for all patients. We have defined which patients can be taken up. And if you see this comparison, in acute coronary syndrome, it showed that prasugrel was found to be better than clopidogrel in preventing complications. In unstable angina, in all acute coronary syndromes, it has been shown to be of benefit, and it also decreased death in this study compared to clopidogrel. So it is a very important medicine which has come up very recently and is very, very effective. But not all patients can be put on prasugrel. Why? Because it is a very strong agent. So all those patients who have a prior stroke or a hemorrhagic complication, or they are more than 75 years of age, or very low weight patients, there we avoid prasugrel. Otherwise, prasugrel can be given to about 80% of the patients very effectively. So that is the second message which I wanted to give. And the third drug which has come up, again an antiplatelet agent which can become a dual antiplatelet therapy with aspirin. So aspirin is constant for all patients. These are the new drugs which we are discussing. This is known as ticagrelor, which was studied again in comparison to clopidogrel, was found to be better. So these 2 studies which have come recently have shown that they are better than clopidogrel, and the event of incidence of stent thrombosis has decreased when we use these drugs very effectively. We were always, very terrified actually with stent thrombosis, because when patients develop stent thrombosis, you have done a stenting in the night, 12 o'clock, they will start calling you up. Suddenly I'm feeling a lot of pain, sweating and things like that. And by the time they reach hospital, they are very, very sick. And we have done already the treatment. So we were always trying to find out what is the problem? Whether it is the stent was not good, the patient is a very sick patient, or the physician has not done the stenting better in the best possible way, or is it the drug which is not effective? And now we are talking of the gene. If the gene is having mutation, it will lead to clopidogrel resistance. And that is how we have found out, and as you've seen here in the study, that prasugrel was found to be more effective in these patients compared to clopidogrel. So these are the studies which have really established the role of dual antiplatelet therapy. Now, these are the predictors of blockage of these stents. When we have put these stents in these patients, the biggest predictor is stopping therapy within 30 days, clopidogrel. And that is why we discuss a lot of times, we give in writing to the patient, do not stop clopidogrel or prasugrel at least for 1 year. And that is why most of these patients should not undergo any elective surgery for 1 year after this stent implantation. However, still many will actually need to stop this drug, but then we have guidelines to take care of that. So premature stoppage of oral antiplatelet therapy is one of the predictors of having complications in acute coronary syndrome, in stent patients, in acute MI patients. And this is a chart which shows that earlier you stop it, the more the chance of death and myocardial infarction. So we have to continue therapy for at least 1 year. So what are the recommendations? It is recommended for all patients presenting with acute coronary syndrome without contraindication at an initial loading dose of 160 to 325 milligram aspirin. Clopidogrel should be maintained for 12 months, and aspirin is recommended for all patients undergoing angioplasty, and for all stable patients, clopidogrel is recommended after bare metal stents for 1 month and after drug-eluting stents for about 12 months. So that is the recommendation. And finally, the take-home message is that the benefit of dual antiplatelet therapy for 12 months following ACS or acute coronary syndrome is very well established. So you have to give it 2 drugs for 1 year at least. If the patient has drug-eluting stents, again continue for 12 months without any high bleeding risk. And patients at high thrombotic risks but low bleeding risk may benefit from dual antiplatelet therapy beyond 12 months also. So you can continue for a longer period as well. So that is the take-home message. And to conclude, prasugrel is recommended these days for all patients undergoing angioplasty in acute MI, which is known as primary angioplasty, for stent thrombosis, recurrent acute coronary syndrome, because patients are on clopidogrel, still they have developed problems, and diabetic acute coronary syndrome patients. Patients who have medical treatment only, ticagrelor is recommended, and clopidogrel is recommended in general for all patients who have high bleeding risk and still need dual antiplatelet agents. So with this, I think I will stop here, and thank you very much for kind attention.